In this short video, we would like to introduce the concept of a negative pressure airway canopy which we have developed in the Ulster Hospital Dundonald in Northern Ireland. This is on the background of increasing concerns regarding exposure to high viral counts during aerosol generating procedures. While there have been many innovative devices which I've described, they have primarily relied on a physical barrier. But we believe that a negative pressure gradient would be an excellent way of reducing the aerosol exposure without compromising the ease of intubation. In addition, our canopy has a flexible physical barrier to help reduce the contamination of those present during such a high risk procedure.
The NPAC consists of a frame, a canopy and a filtered vacuum. The frame lies over the patient's head and torso and is made from 316A4 marine grade stainless steel. It is 30 inches high, 36 inches long and 28 inches wide. It consists of two arches. The 30-inch arch sits over the patient's head and the lower 17-inch arch sits over the patient's legs. The frame is lightweight and can easily be manoeuvred by one person. The cover is made from transparent PVC with Velcro fastenings and is made to fit the frame. It is adaptable at the patient's head opening. This can be fully open, half open or fully shut. The cover has slits at the patient's legs where the vacuum hose is then placed. The cover is disposable and the frame can be easily cleaned.
The negative pressure is generated using a HEPA filtered vacuum cleaner currently available within our theatre department. This generates 22 kilopascals of vacuum and has an inbuilt HEPA H13 filter, which can filter 99.95% of aerosol particles above 0.3 microns in diameter. We have supplemented this downstream HEPA filtration with the addition of an upstream viral filter. The combination is intended to capture the aerosol onto the canopy and only release filtered air back into the theatre environment.
We have tested the canopy with methylene blue nebulization, which generates aerosol of 2 to 10 microns in diameter. This closely mimics the size range of aerosol particles generated during an active cough. It is not necessary to have a tightly sealed canopy, as our intention is to generate a negative pressure gradient to draw aerosol away from the intubating team. This leaves the option to undertake aerosol generating procedures with the flap open or closed as per clinician preference. In the Ulster Hospital, our standard operating procedure is to intubate Covid-19 patients using a McGrath video laryngoscope with a preloaded endotracheal tube on a bougie. Here we are intubating the patient with the canopy half open. We recommend that the canopy is kept closed during pre-oxygenation and during bag mask ventilation, as this is when most aerosol is generated. During an active cough, larger particles will settle on the patient's torso or on the inside of the canopy walls. During laryngoscopy, the canopy can be partly or completely opened to facilitate intubation. As demonstrated here, if the intubation attempt becomes difficult, the canopy can be easily removed from the patient's head to allow further access. Contact with local private enterprise was invaluable in the design and manufacture of the NPAC. The Ulster Anaesthetic Department was assisted by John Clark of J. Clark Marine Limited and Johnny Lynn of Boat Covers Ireland.
In conclusion, we feel that NPAC is an easily reproducible, worthwhile supplement to adequate PPE and may reduce staff exposure during aerosol generating procedures in the current COVID-19 pandemic. Thank you.